All right, welcome back to Paw Patrol with your host, Dr. Jeff Dikis, and I'm joined by Dr. Colin Mizuo. Thanks for joining me.
Thanks for having me, man.
Yeah, absolutely. So for anyone who doesn't know who you are, give them a little bio, give them a little rundown of who you are and where you're at right now.
Yeah, been lucky to been kind of raised had experience living in a lot of different places. Born in Japan, grew up in Texas. That's where I went to college. And found out about kind of podiatry through rugby, through a short stint of that. And then, yeah, kind of everything fell into place. And then I went to school at Scholl in Chicago, and then did my residency at MedStar Georgetown with Dr. Steinberg in the Washington, D.C. area. And then right after residency, I commissioned as a lieutenant in the Navy, and then I got stationed in North Carolina for my first duty station. It was lucky because I got to do kind of my one and done there, and so doing mostly trauma reconstructive surgery at Camp Lejeune in North Carolina. And then once I did my kind of active duty service was complete, then I went back to DC and did private practice ortho group there for a little bit. And then my wife and I recently moved to the Portland, Oregon area late last year. So practicing in a private practice here right now.
Cool. A lot to talk about there. So you and I go way back. If I remember correctly, you rotated through as a student at UPMC when I was there.
Yeah. Yep.
Yeah, for sure.
I was wondering if you remember that. Yeah.
Yeah, I do. I thought you were a great student. And then, just like anything, it just kind of like, you lose track and you never know, like, oh, whatever happened to who, such and such. And you just kind of keep on going with your own stuff. And then things like this happen, we circle back and cross paths again. So it's kind of funny how things, especially in a profession this small, it's funny how often things like that happen, or you find out, oh, that was my roommate from back in school. It happens all the time where I meet someone and they're like, oh, you had my best friend from podiatry school on the podcast. I'm like, whoa, that's crazy. Small profession, obviously. So
it feels smaller and smaller.
Yeah, for sure. Especially with technology and things like that and social media, you just you're able to keep in touch with some people a little easier. So after Scholl, like you said, you went to DC. What drew you to DC? Obviously, that's a fantastic program there with Dr. Steinberg. But what about that kind of caught your eye and made it where you wanted to spend the time in residency?
Yeah, truth be told, it was very similar to UPMC in terms of kind of setup. For me, I've always tell people like I'm a product of, not just hard work, but very good mentorship. That's what I seek out. Mentors have, the people that have taken the time to invest in me have really helped me hone in not only just my craft, but, fuel my ambitions. And I have nothing but the highest of praise to say about, Dr. Patrick Burns. I wanted to model a lot of my career after him. I'll never forget the first time I saw him do arthroscopy. I was so just mesmerized, and that's honestly really why I do a lot of the arthroscopy that I do now. And so I was really wanting to kind of gun for that position. And then Steinberg has a way, he, it was funny when I didn't rotate at MedStar like I did UPMC. I only visited one day. And Steinberg wasn't even there. So I was like, oh, really? Of course not. And then he had me in the interview, just kind of the things that he was saying. He was very captivating. And yeah, he reeled me in somehow. And, it was kind of one of those gut reaction, last minute type of decisions. And I'm glad I went with it because, it's I don't regret it for the world. And he's been a very close mentor, father figure for me, and he even ordained my wedding. So, nice. Yeah, kind of, probably for similar reasons, maybe why you chose UPMC. I mean, it's just a solid program, and it had everything I was looking for. But like I said, the most important thing was mentorship. And I saw Steinberg and I was like, that's who I want.
For sure. Yeah, great program, great residency. Obviously, DC doesn't hurt too. DC is a pretty fun place to hang out. So let's talk about decision to go into the Navy. What kind of prompted that? And give us a little rundown on the behind the scenes. What made that appealing for you?
Yeah, so I have a long, I think, family history with military service. My grandpa was in the kind of the famous 44 2nd Regiment, which was like the Japanese Americans that were in the concentration camps that identified as American, wanted to serve. And then my dad served kind of during the Vietnam era. Luckily, didn't go, but I kind of thought I would always have some type of service, but I didn't know like in what form. I knew I didn't want to be on like the front lines and infantry, but um, funny enough, 2 weeks before I graduated from Shoal, there was a special scholarship program, essentially, which is a track that I ultimately got accepted for.
Hmm.
And I got super lucky. You know, the military, I think people need to know, is not exactly what it seems. And if you go to the wrong people, you can get a lot of misinformation.
Hmm.
Um, I got a lot. Like I said, I got super lucky just in terms of the experience that I had, the people that I got to work with, the the friendliness and the accepting of kind of the orthopedic docs that I worked with. You know, they were really instrumental on feeding me and getting me a lot of trauma exposure, which is what I wanted. So fostering those relationships and them just being open to it and knowing the talents and like the skill set that podiatry offers. And so um, it kind of just fell into place. Once again, I got accepted for it, and then once I kind of did the put the arm up, it was basically I had no way back after that, right? So
Yeah.
yeah, it was great. It
Yeah.
was awesome experience, but it was definitely there's a lot of things that I think people need to know before making that decision, because it could be my experience will not be the next person's. So
How many years was it that you had to serve after
six
residency?
six
6
years of
years.
active
Okay.
duty and then 2 years of active reserves, just depending on the route you want to go.
And they either pay for your school or pay for some of your
Hmm.
school, or are there some
Yeah.
incentives there that would draw people
Hmm.
into doing that?
Hmm. Yeah, half my
What
tuition essentially.
nice. I want to talk about your grandfather there. That is really interesting. So I think that's a kind of a not often spoken about time in
Hmm.
our country. Everyone knows about World War II and what happened with all the battles, but talk about that a little bit more. So there was a the internment camp. Talk about that a little
Hmm.
bit more.
Yeah, so after the bombing of Pearl Harbor, right, and the America entered the kind of both the Eastern and Western kind of war theater. There was a lot of Japanese living in kind of the Western West Coast cities, and
Hmm.
you know, um, they identified as American, but just because of the times had be, right? I mean, the American Japanese, they were seen as a threat, as spies, and so they were all put in concentration camps. And it took a few years before the United States government recognized the plea by a lot of these internment camps that like, hey, like we identify as an American, and we want to fight, we want to show you that we are worthy. And so they're very instrumental on the Eastern Front too. And so my dad was they formed a regiment called the 44th Regiment. They actually made a movie about it that my grandpa played like a cameo in, which was really cool. He likes to
That's
brag
awesome.
about.
Yeah, that's
And
awesome.
yeah, just I think kind of growing up with a lot of like a lot of kids with military parents, you hear a lot of, or grandparents, sorry, you hear a lot of their stories, their experiences. And so those are some of my favorite pastimes and memories of him, of just sharing them over and over. And then as he gets to his older age, we're probably having the same conversation like within the same couple of hours. So it was just, yeah, I mean, I appreciate you kind of highlighting that, because it is a part of our history that I don't think is really talked about a lot of. And yeah, it was you know a very different time in our world, but also just kind of understanding like how different ethnicities and races play into something as catastrophic as warfare. So
I think that's really interesting. I didn't realize that about the regimen of
mhm,
interned captives essentially in their
mhm,
own country that they're living in for a period of time. And
mhm.
that's kind of glossed over, I think, in the history books, or maybe I just wasn't very good at history. So that's very possible too. Maybe I
No, no,
wasn't
it's definitely
wasn't
not talked
listening that
about.
day.
Yeah,
Yeah.
yeah, not on
Um,
you for sure.
yeah, that's really interesting because we're going to get way off topic here, but if we start talking about history, but I do find it very interesting how there's these ebbs and flows of history. And at one point, we're at war with Japan, and now we're very friendly with Japan. People go on vacation to Japan. They may come here, vice versa. It's very
Mhm,
amiable. And the same thing, we used to be allies with Russia. Now, I don't want to get political, but Russia's got its own stuff going on. But it's just
mhm,
interesting how at one point in history we're enemies, and then not that much longer we're allies, and then we go back to enemies.
Mm,
It just really seems kind of silly to me if you think about it too much. Just,
mm,
we're all just people.
mm.
Can't we all just find a way to get along? But that's really interesting about your grandfather. Thanks for sharing that.
Yeah. Yeah.
Um,
And I think too, like, when you think about like when we get away from those historical moments, I mean, like I know history is so filled with so many different things and we can't possibly cover it all in school, but like, when we look at, the tearing down of monuments and statues, and I know some of those may be more sensitive than others, particularly as it pertains to slaveholders and things like that, Confederate states, but like
mhm,
when you do things like that, it helps us, we get more and more removed from history. And then at some point we forget, right? And so, I always
yeah,
kind of tell people that like, even though our history, Western civilization is kind of filled with a lot of nasty things. I mean, if you go back further in the European times, like, 15th, 14th, 13th century, I mean, before the birth of the United States, I mean, it gets even darker then, but like, that's how we learn. That's how we move on, right? That's how history carries forward so that we learn from our mistakes, but we get so
yeah,
far removed from that when we destroy everything that reminds us of those times. So, you know, that's my
yeah.
2 cents on it, but yeah.
No, I'm with you. It's an interesting thing to think about, but I don't think we're going to solve all the world's problems tonight. We can try
We could try. Yeah, it'd be difficult, you know. I
one
don't know if there's
step
an
at a
award for
time,
that.
one podiatry podcast at a time. We're going to solve all the
Uh-huh.
world's problems.
It's a
Um,
good segue.
yeah. So, I saw that you had some decorations when you were in the Navy. I can read them off here, but would you like to talk about those a little bit and
I
to talk
mean,
about?
they're nothing special. Look, I think when I was talking to some other people about that, they like to kind of highlight those, and it's like, look, I mean, some of those were entry level, some of those you just earn with with experience and service years, and
Mhm.
I think I was not the one that had like the huge like row after row, highly
Yeah,
decorated,
right.
because when I got into the military, I knew I wanted to get out. I knew this was going to be once I give my service, I'm done. So,
Sure.
I did kind of the things that were pretty interest, like the war on terrorism, and that was kind of a unique situation and humanitarian kind of thing. And with COVID was, I was in the military during that time frame. So I
Oh, that's
think,
tough.
yeah, those are just interesting kind of side things that I got to experience, but nothing that I would say is worthy of mention when you compare some of these highly decorated people.
Sure. Well, do they have an award for the number one podiatrist in the Navy? Could you at least like
They
vie for?
do. They
Do
do
they?
actually. Yeah, yeah,
Dude,
they
I was
do.
totally
No, they
joking.
do. No, they do. And
That's
the thing
awesome.
I hate about it, because you have to kind of nominate yourself.
Oh,
And so I
yeah.
refuse to do it. So,
Yeah, I do that too. It's
um,
like I'm not nominated. Yeah, I'm
yeah,
with you.
yeah, I
That's funny.
couldn't.
I
I
was totally
couldn't.
joking. That's awesome. They
One
have
of
it
my
though.
friends got it, and I was just like, I just looked at him like, I know what you did, but you
I know
have to
who
because that.
I know who nominated you. You
But
did.
you have to, you did, but you need it to promote, which is a big thing in the military that people don't understand. It's really,
Okay.
it's somewhat easy to get in, but very difficult to stay in because of your promoting status and ability to do so.
I think you're using the word promote different than how it hit my brain because you're talking about ranks in the Navy,
Yeah,
promotion, things like that. But
yeah,
as it hit
yeah.
my brain, I'm thinking promoting yourself, and
No,
self promotion, which is an interesting aspect because it feels weird to promote yourself in this day and age of social media, but it can actually help advance your career if you do
hmm
some amount of self promotion. What are your thoughts
hmm
on social media self promotion? Because it's not really in my DNA to self promote. But having
yeah,
done this
same,
podcast, I don't think I'd have any listeners unless I was out there trying to self promote and get
right.
the word out that it was a thing. So what are your thoughts on social media, self-promotion, and how that plays a role in specifically podiatry, but more so medicine?
Yeah, for me, it's a slippery slope, right? I mean, I don't find any fault in using social media as an advantage to promote your career, to promote your practice. And I think in this day and age, it's almost, I would dare to say, naive not to, right? I
Mm-hmm.
mean, like you just said, if you want to have listeners, if you want to have a podcast that has a success that, yours does, that doesn't come without some self promotion, some self marketing, right? And so I think where I have an issue, at least for me, not for maybe other people, is just, when you promote yourself and kind of the things I see on LinkedIn and other social media, I see a lot of like, you kind of open the floodgates for a lot of ego. And it's like, so for example, when you see a lot of people trying to promote cases that are, whether they're good or bad, right? If you want to showcase a complication you had or how you dealt with it, or just like a nasty fracture, and
Mm-hmm.
then you post like a follow up after surgery, and then people are like, why'd you do this? Why'd you? And then it really kind of tears down people, tears down the profession. So I really try to stray away from that.
Yeah.
I don't like to have arguments, and I think it's easy for people to hide behind a computer screen. And so I really hate that. I'm all for, open discussion and debates, but I just I don't like to, put myself in that position. So I've really kind of gone away from it. But along for self promoting, I mean, in terms of lecturing at various events, I think it's a part of, who but then also like putting yourself out there.
Mm-hmm.
And if people don't see what you're capable, like I didn't get asked to be the vice chair, and now I'm going to be the incoming chair of the postgraduate careers committee. I wouldn't have gotten that if I didn't, one, put myself out there to be in that position, showcase my hard work, promote what I can do and the work that I bring. Um, so yeah, it's maybe a double-edged sword in that regard, but it's just, I guess, finding that avenue and you know utilizing and manipulating it to to make it worthwhile for you. But yeah, there's certain avenues for me that I really just don't really like to partake in, just because of what comes with it.
I don't blame you. I get some secret joy out of poking the bear and putting stuff out there
Uh-huh.
and watching people come out of the woodwork and poking the bear a
Yeah,
little bit more. I
yeah,
think I'm called an online troll, but I get this secret joy out of like purposely putting stuff out there and then keep poking the bear. I
Mhm.
just find
You're
it
one of those.
entertaining. Yeah,
Mhm.
exactly. So, but you mentioned there the Postgraduate Affairs Committee, and specifically you're talking about an ACFAS committee. You want to
Mhm.
talk about that a little more and what the Postgraduate Affairs Committee does for ACFAS?
Yeah, the Postgraduate Affairs Committee is involved in planning the Residence Day and Resident Directors Forum event that is held the day before ACFAS. So it's a forum that it's pretty highly attended, and I've really gotten to see the evolution of it and its success since its genesis about maybe 5 years ago, particularly on the Residence Day side. Um, and it's just, the sessions that we hold are really voted by the residents, the people that have attended the year prior, that, what do they want to see? What do they need help with? We want to offer that service. And it's really the same thing with the Directors Forum, I think this day and age where we're seeing the climate of change quite drastically of what is the resident, both from a psychological standpoint, training aspect, the introduction of AI and the evolution of technology and how it really manifests in our training, the next generation. It's just interesting to see, and I think a lot of residency directors are, there's some that are having a lot of difficulty with it, and others that are, kind of on the forefront with that technology. So I wanted to get involved, and I really I like training the younger generation, the residents, but I didn't really know what avenues I wanted to take, because I know I don't want to be like a residency director. I don't want to be in a big residency program. I think I like more of the intimate one-on-one session. And so I think maybe
Mm-hmm.
training a fellow is kind of my speed. I like to, kind of
Sure.
lock in with one person and see, and because I think you get just a better, you know, visual, and you get to see that person kind of day by day just evolve into, the surgeon and doctor practitioner that they become. And so I like, yeah, like I said, the one-on-one, but this gives me another kind of avenue to kind of explore how I want to, adopt my training and the way I approach, the future generation. So it's been really rewarding.
Knowing you how I know you, I think that'd be great. I think you'd be great at being a fellowship director, or at least a faculty part of a fellowship. So something for you guys to consider
One
for
day.
sure. Yeah,
Yeah.
one day. AI, you mentioned AI there. So it's
Hmm.
a common theme. It feels like if you go back and watch the clips of people trying to figure out what email is and what the World Wide Web is, it just looks hilarious. Like they're trying to figure out like
Hmm.
what's going on, and I'm sure that'll be us someday trying to figure out like, what is this AI? What can it do? What is it for? But it's an
Hmm.
interesting aspect of medicine and our everyday lives that will be infiltrated by AI in ways that we know about and ways that we aren't even realizing how it's infiltrating our lives. But I don't know. Do
Hmm.
you use any AI on a daily basis, either in practice or in medicine, or?
Yeah. I use it to help write notes for the most part. I think just kind of like everybody, I use it for certain parts of the note, not all of it yet, because I
Hmm.
think the physical exam part is, probably the hardest part where there's a lot of issues with it because it's either not specialty specific or there's it's really how you're doing it, right? Are you like kind of just verbalizing it, or are you having something listed in on while you're in the room? I think that's kind
Yeah.
of the next forefront. And I played with a couple of them. It's just been too many mistakes, and I end up creating more work for myself, having to go back and fix those. So, and
It's
then there's another one that we're trialing that's listening to we have to verbalize what we're doing in the OR, and then
oh, okay.
it writes our dictation for us.
Okay.
Um, it's been a little iffy, but the idea is that the next wave is that they want to have a visual thing after
Hmm.
there's been so much dictation component that as it visualizes, that's kind of like an eye in the sky, and it can actually dictate the report just based on seeing what we're doing. It's weird, man. It's just where we're
There's
going
two
is just interesting.
two thoughts that I had. The first is that I think it's hilarious when when you're using a program that's AI to write your note to try to help you do the physical exam, and all I'm
Hmm.
picturing is like, I am now palpating the dorsalis
Yeah.
pedis. I
Hmm.
am now doing
Yep.
range of
Yep.
motion of the hallux. It's like,
Yep.
I'm not going to say
Yeah.
that out loud
I
as I'm
know.
doing it. It's
I
like
know.
the
I know.
silliest thing I can imagine. The patient's going to be looking at you like, what is wrong with this guy? Why is he saying all this nonsense? It's
Yeah.
like just so silly. It doesn't work so hot for physical exam. And the second
No.
is, I instantly, when you said that something was going to be watching, I instantly thought from a medical legal standpoint, if it's like recording the video and then they could go back and be like, see, there's where you made your mistake. See that's the thing that you
Hmm.
shouldn't have done. Like,
Hmm.
there's a lot of good that comes from this, but there's a lot of
Hmm.
potential pitfalls I can see that I think they're called unintended consequences. And every time you
Hmm.
make a move, there's an unintended consequence. So there's a lot to
Hmm.
unpack there from an AI standpoint. But I think
Yeah.
it's just important to realize that it is a thing, that it is helpful. And if we utilize it properly, it can make our lives easier.
Yeah. Are you using it in practice yet, or anything?
Um, I've used the notes
Hmm.
component of it. I found that I was better without it because
Yeah.
even when it would do the note and then I would copy and bring it over, I was having to proofread it and edit. So by the time
Yeah.
I'm reading it and proofreading it and then going in and making edits, I found it was faster just to
Yeah.
just dictate
Yeah.
with Dragon or M
I
Modal or
agree.
whatever you have. So I
Yeah.
don't use it, but I could see why it would help some people be a lot more efficient and a lot faster.
Hmm.
You posted one time a really, really interesting thought on an app called 15 Blades. I've had David, the creator of
Hmm.
15 Blades, on before. So if anyone's
Yeah.
hearing this and not know what it is, just Google it, look it up. Basically, it's social media for only physicians. But you posted a really interesting case where you had an osteochondral defect, partial detachment, and you basically went in. So for the younger people listening, usually if there's an osteochondral defect, we'll go in and we'll just take it out, and then we have to try to find a way to create new cartilage and replace that somehow. But basically, you had just reattached that portion of cartilage
Hmm.
defect. I want to talk
Yeah.
about that a little bit in terms of how you think that works. Is it successful?
Hmm.
And because in my mind, if we're taking out the old piece and we're trying to grow something completely new,
Hmm.
maybe to be semi-native cartilage or at least similar to native cartilage, but it won't be quite
Hmm.
as good as the actual native cartilage. That maybe if it was viable, you reattach it and it's better than anything that we're going to grow in its place. What made you
Yeah.
think to do that, and how do you feel like it has worked?
Yeah. Honestly, it was just kind of the thought randomly just occurred to me when I got the consult for it and I saw it. I was like, oh, it had been one of the I had. Sorry, let me actually go back. So the first one that I got, I actually took out, and and then I was just looking at it, and I just was like, huh. And then without really any thought thinking about it, I just did I think a de novo or some type of resurfacing agent, and then later that evening, I was like, man, like you know. When you think about cartilage, especially on the adults, right? I mean, it has no nerves, no nerve endings, no vascular supply, right? It's just mostly water, proteoglycans, and So essentially, what is the time frame when we damage cartilage of how long that can survive? Like, what are those chondrocytes doing that,
Hmm.
from an injury, remote injury, and with detachment that those can survive? And so when I tried to look up the literature, there was just very few data looking at that. There was a couple of reattachment surgeries that were more case studies in the knee that ended up doing fairly well. And
Hmm.
so really from there, the next one that I got, I was like, all right, if I can, I'm just gonna, look at it through a scope, kind of, pull the piece out. And if it looks, kind of like in a bone, if it's pretty simple and not comminuted, then I'm just going to reattach it. And that's what I did for a couple of, actually I got several of those under my belt now, or at least within the military that they did very well. And kind of like you were saying, it's just like, if I expose that bone and then I put that resurfacing agent, because, we know that really, most of the products out there, if not all, just reproduce fibrocartilage. And obviously something is better than nothing. And then even with de novo, Lucian has an article that, granted, these are his failed cases, but he was taking a second look arthroscopy, doing a biopsy on them, and even found that there was a mix of, hyaline and fibrocartilage. And so, is there something to be said that about that de novo that's supposed to produce hyaline cartilage, but it's really not? And so, I just kind of like you were saying, I think if this is a healthy piece, just like a bone, I know makeup is very different from a biological standpoint, but what is it to say that we can't reattach those within a certain time frame? And then I think the next research question is, well, what is that time frame? Is it a week,
Hmm.
2 weeks, 3 weeks? Every one that I've done has been under 2 weeks, and I haven't had a failed one yet. So
And what
kind
are
of
you
we'll
using to
see.
reattach?
A fiber and glue, yeah,
Okay.
which is something pretty interesting because there was another study looking at fiber and glue, kind of just in general, and seeing how that actually impacted chondrocyte migration to the native cartilage and somehow impeding that. Now, I haven't really had any issues. I've had a lot of good stuff coming from that I'm publishing and just from an anecdotal standpoint. But yeah, it's just something kind of food for thought too. I think now on the horizon is there maybe a better product out there that can provide a sealant but not any impedation between whatever graft you're using and that surrounding cartilage. So
There you go. There's your idea. A
yeah,
cartilage glue that
yeah,
creates a scaffolding between old and, well, I guess old and still old, but native and
right.
native. That's really
Native,
sounds better.
yeah,
Sounds better
yeah.
that way. So my thought
Mhm.
process when I saw that was, does it make a difference if it's a Burton Hardy 2 with some partial detachment, or if it's a 3 or 4 and it's been
Mhm.
completely detached? And
Mhm.
to me, it makes sense if it were a 2 that you're just kind of flap it,
Right.
stick a little, lift it up, put a little fiber and glue under there, flap it back
Mhm.
down, and let it
Yeah.
hopefully remodel, versus like a 3 or 4. Maybe it's become, I'm not smart enough to understand how the chondrocytes stay viable, if it's the fluid that it's living in or if it's the attachment to the subchondral bone. I'm just not smart enough to
Mhm.
know that. But if it's become detached, does it make it non-viable, or is it still viable? And the ones that you've done, have they been partially detached or fully detached?
Both. Yeah, both, and they've
Really?
all both done really, really well. So, yeah, I would say it's I think the same thing. That's kind of like what my pending research questions and something I want to kind of study further. But yeah, I think I've always kind of wondered, does the health of the cartilage, when we look at cartilage, does its health and integrity depend, on the individual basis of cells, or is it on the environment that is supplied by the entire surface of that cartilage, right? And so when you have something that's fully detached, now it become very independent. And does it kind of almost act on and survive on its own kind of integral structure? Or is it, like I said, reliant on the surrounding tissue? And but like I said, I've had pretty good results with them, and I've had even post-op MRIs. And I know there's, with the MOCART scoring system, there's a lot of, kind of misleading information because they don't even correlate with functional outcome scores, right? And that's been shown in several studies. So I don't know. I think I just am too cautious to say because I've only had I think 15 in my total career. I just don't really get them a whole lot. where
Uh-huh.
they're just kind of free floating in the ankle joint like that. So,
Sure. Do you dry the environment and then put the fiber and glue in and then reattach it? Because the fiber and glue obviously has to be in a dry environment. So I assume you're scoping it first, then you're drying it, just like you would with
mhm,
using a juvenile, some sort of cartilage adjuvant. But you're drying it
mhm.
out, then putting the fiber and glue, then putting the piece down, and then that's it.
Yep, 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 exactly. Yeah. Yeah, cleaning out any synovitis and all that good stuff. Yeah, and then drying it out, fiber glue, reattach. So
That's really
yeah, I usually put like a
interesting.
Freya to smash it down, and that takes. I
Yeah.
probably hold that thing there for like 5 minutes, which is annoying. So
Yeah. Yep.
yeah.
Yeah. Yeah, that's like that. Waiting for the prep to dry and waiting for the fiber and glue to set up are the
Uh huh.
longest minutes of your entire day. There are no
Yeah.
longer minutes than those. Um,
Yeah. Yeah. Maybe a
what
microwave minute, but Mhm.
was that?
So maybe a microwave minute, but
Yeah,
when you're hungry at midnight waiting
yeah,
for that food to
that
come.
one's tough too. That one's tough too. Um, yeah. So I wanted to go back for a minute, and after you went to the Navy, and then you knew you
Mhm.
were going to leave the Navy, you found a job. What do you think for any of the younger people listening? What is the best way these days to find a job? Because you've now made a couple of different transitions in your career.
Oh man, I would say.
How did you find a
I
job? I
mean,
mean, just tell them your story. Word
yeah,
of
I would say. I
mouth.
mean,
You
first,
seeing
it's
advertisements.
it's starting with the people you know. I mean, that's the big thing, right? Is starting with the people you know. Using your network, using that black book of connections that you have that you've made along your residency. I think that's really one of the benefits of going to all those conferences. Hopefully you get some type of supplemental financial support, right? When you're as a resident to go to those and you meet people, you meet other residents, and yeah, I mean that's the first way, and then I think 'cause I get asked this question quite a bit, and it's so hard because it's like, okay, well, first off, like, do you know where you want to go, right? And I would say start there, right?
Yeah,
Geography. Is there some place that you're kind of maybe anchored to, and
yeah,
then after that, it's just starting with the Google search, who's hiring, but starting with that black book is 'cause you probably know too. I mean a lot of jobs are not posted, right? People
right.
want someone that they've known or they can get vouched for, right? And yeah, it's just there's just something more settling about that when you have someone else that can vouch for you, and I think that's kind of unfortunately for better or for worse, the way the world works, and um, so yeah, that's what I did, and it was really easy for me because I went back to DC where I did my residency. So I had a lot of networks, a lot of people. I didn't. I mean, it was just super easy for me because I got to work. I worked with, and the job that I ended up getting was someone that I had worked for during residency. So
Hmm.
just showing up in cases. So I think the interview almost starts kind of like when you're in residency, especially if you want to work in that area. So
Yeah, I agree.
don't burn those bridges. Mhm.
Yeah. Um, Yeah, I was just thinking of how I would do it if I was going to hire someone, and I would not post a job on just any old website because I'd get
Mhm.
300 applicants that I'm trying to sift through. How could I possibly narrow that down?
Right.
And it's just going to be a bunch of people that I don't know. I would start with
Mhm.
people that I know. I would start with people who are local. I would start with letting my reps know that I'm hiring someone. Hey, if you hear the word out, or any of the residents looking to stick around or anybody's looking moved back to the area, I would let my reps know.
Mhm.
They're probably a good resource is knowing reps in a certain area because they've got their ear to the ground whether they want it there or not. They're just constantly in the hospital and hear a bunch of
Yeah.
goings on. So
Mhm.
yeah,
Mhm.
but I completely agree with you because I think I hear people all the time. There's no good jobs posted. Like, well, yeah, there's a kind of a reason for that.
Right.
Um,
Yeah.
I just think about what I would do, and I would not just blast a post out there and get 300 applicants of people that I don't know. It's just not what I would
No.
want to do.
It's no different than when you're applying for a fellowship, right? I mean, yes, you got to have foundational skill set, knowledge base, right? But at the end of the day, a lot of fellowship directors are looking for someone that they can vibe with for a whole year, right? I
Yeah.
mean, it's the same thing. Like, you know, does this person, are they, do they want to work hard? Do they want to, are they surgically inclined? Do they have a good knowledge base? Okay, great. but a lot of people have that, right? And so then it's kind of personality, and are they going to vibe with the staff? Are they going to vibe with the rest of the docs and colleagues, and
Yeah.
kind of the face of the practice in a way. So yeah, it's just it's no different, you know. I think, I mean, that's just kind of the way the world works, right?
Yeah, for sure. All right, you want to jump into some cases here and dive a
Let's
little
do it.
deeper into arthroscopy and ankle
Yeah,
OCDs.
let's do it.
Can you see that?
Yeah.
You want to talk about this first case here?
Yeah. This was an interesting case. This is actually one that I had a very good picture, illustrative picture, and then a arthroscopy image to back up what I was seeing on an MRI. Because I don't know, you know, for my arthroscopists out there, but when you do enough arthroscopies, you'll see this like this fibrous band at the front of the ankle that you know, a lot of patients will complain kind of secondary to some type of impingement related syndrome and maybe even the gutters. And so there
Yeah.
was this actually I think I actually pulled this out of a textbook, and then there was some other supporting literature that I found about this fibrous band that it's not found in all everybody, but kind of expands across the ankle joint.
Hmm.
And then when loosely attached, it's supposed to be kind of synonymous with the ankle capsule, but when it becomes loosely attached, it floats around as you see in that arthroscopy image. And so typically I'll debride that out. But it's difficult to see on MRI sometimes. And when you see on that MRI that correlates with that arthroscopy image, it's just a bunch of like, you know, synovitis, inflammation at the anterior aspect of the ankle. But you can kind of almost like see it there. But when I see a lot of that inflammation kind of really targeted in this kind of fashion, then I kind of assume, oh, maybe there'll be this little fibrous band that needs to be taken out or removed. So
This is definitely something that radiology will just say, you know, global edema within the ankle joint or
yeah,
something. They're not going to be
oh
able
yeah,
to, it's
nah.
not their fault. They can't see this fibrous band. But anytime someone complains about impingement or catching or locking,
Hmm.
definitely, I already know. As soon as they say those words, I'm thinking scope, scope, scope.
Yeah, yep, totally agree.
All right, what about this next one here?
Yeah, so this is why I routinely perform an arthroscopy about 99.9% of the time when I do lateral ankle procedures,
Me
is because
too.
you get this, you know, you get this significant amount of inflammation, this synovitis that you can see throughout the imaging, kind of yeah, and it's just, if you don't clean that out, you know, and a lot of, believe it or not, you know, I've done this in military people, active duty military, where they didn't have the time to undergo an ankle procedure for stabilization. I mean, but they just had ankle pain, and just cleaning this out, I
Yeah.
would say 90% of them were almost completely better. You
Yeah.
know, now they still had the instability, but they were able to do what they needed to do, and then, you know, follow up at a later date and get their stabilization procedure. So, yeah.
And with the instability, you can at least brace that. You can't really brace this
Hmm.
interpositional synovitis you know,
Hmm.
type, you know, pain. So at least with the stabilization, there's something external they can do. But yeah, I agree with you.
Yeah.
Cleaning this up, and I scope every single, you know, if I'm doing a perineal tendon repair, I'm scoping the ankle. If I'm doing a lateral
Hmm.
ankle repair, I'm scoping the ankle. And I find
Yep.
stuff. I'm shocked. There's been like twice in 10 years of doing this, I stick a camera in there, like,
Hmm.
huh, actually looks pretty good. But
Yep.
almost always you find something in
Yeah.
there. You're like, yep, I can
Yep.
clean this up. Yep, we can make this better.
Yeah. And so this will kind of go into a later discussion, but um, I'm a very big proponent of CFL repair. Not in every patient, not every stabilization or lateral ankle instability patient needs a CFL repair, but it is one of the most common causes of reoccurrence. And so this is something that I put in one of my published papers that is pending, but this is actually a relook at the ankle joint with varus tilt, both pre and post rostrum. It just
Hmm.
doesn't make any sense to me why, when you have a really nasty ankle sprain or a chronic ankle, and I know CFL sometimes integrity is very difficult to assess both clinically, and the MRI image is really difficult to get to capture that CFL because of the orientation of it.
Hmm.
But this is something I really wanted to show people, that, you know, in chronic ankle instability, when there is suspected CFL integrity compromise, that even if you do a rostrum, you go back in, you put the ankle in the neutral, invert it, and then you get this varus tilt again. So
I 100% agree with you, and I've been saying this now for a while. You and I are thinking along the same lines, which is ATFL. We test it with an anterior drawer, and we know that
Hmm.
CFL is talar tilt, and then we go in and we fix it with an ATFL repair, and we're like, okay,
Yeah.
job well done. And you're like, wait,
Right.
I thought we were having the talar tilt and the lateral ankle instability and the weakness of the lat. But why are we fixing it feels like we're focusing on the wrong ligament. I've always thought
Yeah.
that. I'm like, why are we so
Hmm.
focused on the ATFL when the CFL is limiting the inversion and leading to hindfoot
Hmm.
varus? But I completely agree with you. So then are you a big
Hmm.
proponent of CFL repair like you alluded to there?
Yeah. So if I like this is been very, I would not with 100% certainty by any means, but this has been pretty near almost diagnostic for me. So yeah, if I think in the acute injury, it's really tough. But once they're under anesthesia and they're not guarding anymore. But yeah, like I said, I'll just I'll do my brostrum, and then if it's an acute injury, unless it's an athlete that's looking for some type of internal fixation, or augmentation, I should say, um, I'll do a primary CFL repair. But it really depends because a lot of these, I don't get them acute, right? I mean, and even if
Yeah.
they are acute, they heal fine if managed appropriately and swiftly. But in the chronic issue, that's where I do see some kind of laxity to the CFL. So I'll go in and just kind of imbricate that like a pants over vest technique. And
Hmm.
then, if they want augmentation, then I'll do something for that.
I think people don't tackle it as much because it's not as easy. The ATFL is
Yeah.
just sitting right there. It's easy
Right.
to find. You find the distal tip of the fibula and you're already, halfway done. To get to
Yeah.
the CFL, it's obviously a much deeper dissection to get either above or
Hmm.
below the perineal tendons. You have to incise through the retinaculum, get it out of the way, and
Hmm.
get deep access in there. And I think it's just this. I don't. Laziness isn't the right word, but it is more complicated to go tackle the CFL than it is just to do a primary
It is, but
ATFL
I
repair.
I would agree. I'll say it too because I think it is a bit of laziness. It's like, I mean, yeah, you have to go, go through the sheath. You have to go through the retinaculum. You got to. That's what you just got to do to get to it. It is
Hmm.
There's extra anatomy to get to the CFL, and you can do people do AFL repairs in like under an hour, right? And when you do the CFL, you got to go along the perineal. Sometimes, I mean, you can even modify it, just extend it. It's a little bit harder because you're fighting soft tissues, but
Hmm.
people just don't want to do it. But at the end of the day, it's like, okay, when we go back to who's the one suffering, it's the patient, right? And it's just like to think that you can fix the ATFL, which like I don't know how many articles that I can reference show that it resists rotation of the ankle,
Hmm.
really, of the talus,
Yeah.
not necessarily inversion. I mean, it does a little bit, but um, the yeah, I just don't see how you think you can do a primary ATFL repair, even with augmentation, when there is CFL injury, and think that you're going to have a good result, right? I mean,
Yeah.
yeah, so
I agree. Let's keep going, and then we'll talk more about that because I want to tell you what my technique is, and we'll dive a little deeper there. But let's keep
oh
going.
yeah,
This next
absolutely.
case here.
Yeah, so this is just an ankle fracture. So I just wanted to, if you go to that next slide, the same thing. I routinely scope all my ankle fractures. The ones that I don't do all the time will be pilons, which I still do, but I'll try to reduce the pilon and then kind of confirm
Hmm.
because that fluid has to go elsewhere, right? And when you have a pilon, I mean, a lot of that fluid from the scope is going to go into the soft tissues, and it can lead to a lot of swelling if you're in there for too long. So
Sure.
case by case on those, but this is example of when we look at the literature once again, you're seeing anywhere of reported as low as 30, but as high as 70% of cartilage injuries with an ankle fracture, and so you won't know what you're missing if you don't put a camera in there. And once you put metal, then you've kind of, even with a metal suppressant MRI, it makes it really difficult to assess the cartilage or the ankle joint anymore from any OCDs that you may have neglected. So this is, kind of an example of that where there's been pretty significant cartilage damage. So,
Yeah, I think if I was going to play devil's advocate, I would say that even if you even if there is some cartilage defect, it may not be something that turns symptomatic. So you might be curing something that wasn't going to become symptomatic. Now, devil's advocate to myself, I'm back on your side again. If it's the patient and you have an injury, why wouldn't you want your physician to know about it and address all of the pathology at the first surgery rather than waiting and figuring out whether or not something becomes symptomatic down the road and fixing it primarily?
Mm-hmm.
You like
Yeah,
how I
really with
switched
these,
sides there?
I did. I see what you did there. I like it.
Covered all my
But
bases.
you did, yeah. That's a crowd pleaser right there.
Smart.
Smart, very smart. But
Yeah.
no, I mean, even with these, because a lot of times too, like I'll tell patients, look, if we have an OCD, and it's not necessarily I'm going to fix it, but this is a lot of the times too when I'll see like a loose fiber, like a cartilage flap that I
Mm-hmm.
could potentially just squish down. And
Yeah.
I've had a lot of those, surprisingly, with these ankle fractures that I was able to just kind of, all right, we can just primarily repair that. Because I
For
always
sure.
tell patients, like, look, because I completely agree with what you were said. I mean, I think sometimes people misunderstand that, like, because I love cartilage defects all the time, that I repair them all the time. Like, no, just because you have an OCD, if you had it acutely from an ankle sprain, doesn't mean you're going to be symptomatic. It doesn't mean
Mm-hmm.
that you can't form fibrocartilage, right? If you have a defect
Right.
to the cartilage, your body can replace that, just like it has time and time again with that we've seen. But in the case that it doesn't, that's when I suggest surgery. But yeah, for me, it's just like now that I know that that's there, if you were to have pain in the ankle later, well, now we know, and it's likely due to this because remember, if I'm repairing an ankle fracture, now I have metal in there, and so making the MRI is a little bit difficult. And sometimes the CT is, it may not show. I don't know CTs, and I have love-hate relationships with CTs with cartilage defects, but they can be very beneficial,
Yeah.
especially when there's a lot of marrow edema that sometimes hides a cyst. That can be
Sure.
pretty helpful. So,
You got me thinking there. So it's really interesting because most of the time I don't scope ankle fractures.
mhm,
Not really a great reason. I just don't tend to do that. But what you said made me think. I fix lots and lots and lots of ankle fractures, and some people
mhm,
heal up really quickly and do fine, and some people have this lingering pain, and it seems to take a lot longer to heal. And in my mind, I'm just thinking, well, some people heal up faster than others, but there could be some sort of intra-articular pathology that I was not aware of that could be prolonging the healing for some of these people. So, all right, starting now, I'm going to start scoping on my ankle fractures.
let me know. Let me know if it changes. I'm excited. I'm excited for this journey you're about to take.
Me too. Me too. All right,
um,
what do we got here? Ankle
this,
OCDs.
yeah, I think this is just kind of a segue into the topic. And so, yeah, this was a pretty interesting one. This was one that obviously ankle sprain. You can even see on that right image, the talus is anteriorly dislocated or kind of
Yeah,
anteriorly moved
subluxed. Yeah,
relative to the tibia,
yeah.
and a lot of inflammation. But then, yeah, this is one that I like to show because it shows you. I think a lot of people, a lot of my colleagues that I've asked are like, "Oh, M block," and I'm like, "Well, let's we can try something first." And
I agree. I like that
um,
as a revision option.
yes, exactly. If that fails, and you basically pigeonhole this person into a fusion and or a tail ankle.
Mm-hmm.
So yeah, this is one that obviously you can see the cystic changes here. And so my biggest thing that I always tell people, like looking at your cartilage as like a roof, right? When you have a damaged roof, the underlying infrastructure, the woodwork, right, that supports that roof is now that is now open and can subject to like rain, which is the fluid in the joint that comes and makes that rotten the cystic
Mm-hmm.
changes. So if you just repair the roof, but you don't do anything to the underlying infrastructure, you're asking for a disaster. So whatever it is, I'm not the biggest component of chondroplasties. I still do them, but I actually like to just, get an extra cannula, get bone graft that I harvest from the calcaneus. I
Mm-hmm.
still do this arthroscopy. I haven't had to, really open a lot of these. And then kind of the same way you push a de novo or a biocartilage graft in there,
Mm-hmm.
I just get like an obturator and push that in with the cannula and feed that in. And so, if you go to that next slide, um, this is the defect. This is kind of the step by step putting the biocartilage in, and then those
Yeah.
bottom two, you see the fiber and glue sealant going on top. But you can see here interoperatively how the probe is going down. Once again, you know there's a cyst there. That subchondral bone is fairly firm, and so if you see diving in, then
Yeah.
you know, oh, there's probably a cystic change there, which is what you confirmed on the MRI. Um, but yeah, if you go to that one more slide, I think you'll see like the before and after. So
Mm.
kind of the before and after, 8 months after,
Yeah.
on all different planes. You see the tail is kind of back under the tibia. So yeah, I was really, really, really stoked with this one. This person did amazing. This was active duty military. So she was an infantry
This
soldier.
this is how I do my OCD repairs. Exactly what you showed there with I do a little bit of microfracture. I clean it out. I don't do the
Mm-hmm.
bone graft. I like that idea. Microfracture a little bit, stimulate some healing, and then
Mm-hmm.
put the biocartilage in there and put the fibrin seal over top. And people do really really well with that. I've been really happy with it.
Yeah, nice. Mm-hmm.
That's this is a
Oh,
lot deeper, isn't it? This is a big
this is a big one. This is a
yeah
biggie. Yeah,
yeah
yeah. This was almost a little bit more posterior. This was actually um, a one of my friend's father. He came with this guy, and so same thing. Everyone was telling me M block, and I was like, well, this would be something one that I would have probably maybe considered, and I was even considering doing a medial mal takedown for something this substantial.
yeah
But I wanted to attack this arthroscopy first, and so that's what I did. And I actually just got his MRI, and I wish I would have put it in because you'll see it's amazing. Same like the last one, but
yeah
you can see how huge this is. And so the dome lesions are really, really difficult because you don't have this like either medial or lateral buttress, right? And so, I try to preserve some of that kind of, and it's not necessarily a technique, I would say, but you can see kind of on that second from the right picture, that kind
uh-huh
of cliff that I've kept intact. And that's something that I routinely do for these dome lesions, because it gives me kind of like a gorge or a trench to put this graft in. Otherwise, it's just going to fall into the gutter.
yeah
And you really see how I got to fill that up. But same thing, bone graft. Um, and then the biocartilage on top of it, and then the fiberglue sealant. You can see that the final product on that bottom right. So, and he did really, really well. He's back golfing. He actually sent me him and his son golfing, and so they're doing great. So,
nice. Do you try to fill up the entire defect till it's flush with the surrounding native cartilage, or how much are you putting in there? Are you leaving it a little low, or are you leaving it a little
little
proud, or
low,
are you going flush?
little low. Yeah, when you look at kind of the more common complications with these are typically hypertrophy of the cartilage graft. Now that doesn't always correlate with functional outcomes. I would usually say the literature supports that it doesn't, but
Mm-hmm.
yeah, I tend to put it a little low. One thing I was going to ask you: do you put any like PRP or bone marrow aspirate? Do you mix that with your graft?
Yes, I do. I do add
Yeah,
PRP to it.
you do. You add the PRP. Yeah,
Yeah, I think
I've
it makes it a little stickier. I don't know whether it's making a difference or not, whether it's the juvenile cartilage that's causing the success or the combination with the PRP. I don't know, but I do spin it with PRP.
okay. Yeah,
Do you?
I've gone. I don't have a. I've been going back and forth with bone marrow aspirate and PRP. Um, because I was getting a few more than desired hypertrophy cases.
Yeah.
But then I stopped using it, and then I was doing really, really good. And then I was like, oh, maybe in an older patient that may have a harder time regenerating. So I'm using it on my older patients now. My younger patients, no. Um, so yeah, it's really hard to say if these have like a synergistic relationship or if they're maybe adding to a problem, like I said, with the hypertrophy. Um, but once again, with the hypertrophy, that's easy. I'd rather have that because I can go in, I can shave that down.
Yeah.
Um, so
Sure. Yeah. I'm not sure. I don't know if it makes a difference or not. I think uh, I almost always draw blood, spin down PRP, mix that with the product, inject that, then cover it with the fiber and glue, and people seem to do pretty well with that. So I don't, again,
Yeah.
I don't, it's hard to tell unless I did a 2 arms of a trial and, split them up and did half
Yeah.
with and half without to figure out if it made a difference or not. But
It's the next thing we'll do.
yeah, there you go. I
Mm.
don't have enough going on.
Mm.
You don't either, I'm sure.
Um,
Yeah, what's this one here?
So, man, yeah. So this is the Macy. So this was something I was kind of pretty proud of. I was the first one to do this at a military base in the United States, and just like we deal with bureaucracy and politics and hospital systems, that's exactly what I dealt with in the military.
Mm.
One day I woke up like a typical day, came to work, and we got this like white paper saying, you're no longer allowed to do cartilage or certain grafts. And on that list was biocartilage, de novo, um, orthocell, and all these other stuff. And it's like, dude, I literally have people sent from Germany, Japan, across Africa, even, internally domestically US that are sent to me for these procedures. That's kind of
Mm-hmm.
the name I created for myself in the military. And so I was doing a lot of these, and you're taking away the thing that I do the most.
Yeah,
And
right.
so I had to find, and I was still getting them. And then luckily, so I went to one of my ortho surgeons, Dr. Harvey, and she's kind of like the queen of these in the knee. And so the Macy procedure is a two-step procedure where kind of seen here, you're taking a biopsy of the cartilage. Some studies say that you can take it from the periphery of the lesion, which I didn't want to do because I just didn't know in terms of the viability of those cells. But there is an interesting article by Krulin that showed that those cells they have about a 94% viability. So
Hmm.
anyways, that aside, I was taking it from the anterior aspect of the ankle, which you can see in that bottom right image, and that's a fairly non-weight bearing surface of the ankle. So that's the reasoning why I took it there. And then you send it to a lab, and takes about 2 weeks, and they basically regrow cartilage on a matrix. And so um, the second stage is when you get that graft is implanting it, and it can last a year. So, but it's ready in about 2 weeks. Um, and so if you go to that next slide, um, you basically start to see this is stage two. You're prepping it. So now the whole lesion is you try to make a geometric shape. In this case, it's kind of an oval.
Mm-hmm.
And then I use the kind of interfacing of a suture packet and cut that to size, and make sure that it fits in the lesion, which you can see in that bottom right image. And
Mm-hmm.
then I use that as a template to cut my graft. And so I think you'll see that on the next slide. Yep. So I'm making arthrotomy for these. You can see it externally on that left image. It comes in
Mm-hmm.
this like kind of free floating, put it on the thing, and then you can see my graft. I cut that to size. And then there's the matchup on the right. And then the next image, the next slide is implanting that graft into that defect.
Hmm.
And so, yeah, I'm publishing a prospective study on this on the active duty military, hopefully to get it out that next year. And yeah, all of them, 100%, they all stayed in the military. I'm glad, but also very um, underpowered, low cohort. I mean, this procedure costs 43 grand. It's
Hmm.
covered by insurances in the knee and the hip, but it's not covered in the ankle. And so I hope to, you know, be on a task force one day to try to get this, which I'm on with APMA, to hopefully get this approved, because I think it could be very beneficial.
So you showed them. They took away your biocartilage and your de novo to save money, but you showed
Yeah,
them.
right. Thank you, everybody, for your tax dollars. It went to good use, I promise. But right, it's
Did they tell
stupid. Like
you?
that's how dumb.
Yeah.
That's
Did
how
they
dumb it is.
tell
Like
you
you will
why they
pay.
took them away?
No, it's people in a suit, just like in a
Yeah.
board that have no
Yeah.
business making these decisions, probably just to try to cut funding.
Yeah.
But then they do stuff like this. It's like, why would you approve this? So,
Yeah.
yeah,
It's wild. It's wild.
it is. It is. So, this was a cool one because, yeah, if you go to that second image, it's the same thing we're doing at Macy, but on that bottom right, I did a second
Mm.
look arthroscopy for a study. You can see kind of how that integration has really
That's
set
cool.
in. So,
That
yeah,
looks that
yeah,
looks great.
yeah.
That's really cool to be
So,
able to go back and see what it
yeah,
looks like.
it's difficult to let people talk talk you into it, but she was really,
Yeah.
yeah, like, let's do it for stuff for research. I was like, perfect. So
Awesome.
yeah. And
Oh,
so just like I said, I scope everything. So this is just a case of just a tendoscopy, I think something that maybe will get more and more utilized as people get comfortable, especially with the innovation of the nanoscope. I think getting a 2.7 scope can be a little bit difficult in there, but the nanoscope has made this super really easy, and it's kind of bendable, and so a little bit more of a flexible device. So here there's a perineal brevis tear with a lot of fluid there, and I think the next slide, it's really weird because you're in like this alien world, right? And so as you're kind of migrating down toward the tendon sheath, you start to see the tear occur, and then you can see a bunch of the inflammation on that bottom right. And then I
so
went ahead and opened this up. So
yeah. So is this like diagnostic for you before? Because you can't really do much. I mean, you could maybe stick a
hmm
shaver in there and clean up some loose
yeah,
ends, but you can't really. Obviously, you can't tubularize or do anything to the actual tendon. So
yeah. So for me, the reason why I did this one because I think it was pretty obvious on the MRI that this was going to have a tear.
Mhm.
And so for me, I wanted to, this was actually one of the first ones this was the first one I did. And I wanted to just get comfortable with the scope with doing the tendoscopy. So I was like, all right, let me just try this. I know I'm going to open it up anyway, but let me
Yeah,
just, it's sometimes a little bit hard to find the sheath, and then the tendons glide on you. They kind of,
sure.
before they go into their own sheath.
Yeah,
And it makes it really difficult. It's even like I can debride these out pretty well now, but I've seen some people try to do this. I think that there was an article I read that someone was doing this through a scope to repair a tear, and it's like I'm not going to do that. I'm just going to open it up. I can be much
yeah,
quicker and
right.
thorough. And so yeah, so this is diagnostic for me when the MRI sometimes is very inadequate at showing on whether or not there's a tear. I think what was it Sharp? Dr. Sharp had that study that showed kind of the inconsistencies, really looking at the MRI versus reality of a tear, and I found that to be very, very correct in my practice. Like so many times an MRI has burned me. So
Yeah. Sometimes we call it the MR lie because it lies
yeah,
to you and you're like, there's no way this isn't torn and it doesn't look terrible. Then you get in there and
hmm
in the real world and it looks awful or vice
yeah,
versa. Not usually
hmm
very common the other way where it looks terrible and then you get in there and it looks fine. That is
hmm
very uncommon, but pretty
hmm
common where you get an MRI, you look at it, you're like, I don't know, it doesn't look that bad. And even sometimes a radiologist will be like, no signs of perineus brevis tear. And I'm like, I beg to differ because I've
yeah,
seen enough MRIs and I've seen their symptoms. And I go in, I open it up. Yep, sure enough, clear as day. There's a terrible tear
yep,
in there. So
yeah.
MRI is tricky.
It is,
It can lead you astray sometimes.
yeah. And so that's just a repair, just showing the tear. So yeah, just did, like I said, open these up, primary repairs, and I think these are different studies. I don't even know why I had these on there. I think actually this kind of made its way at the end, but this was just like that looks like one of the graphs that I used for a perineal tendon tear that was neglected. So
Mm, that's a
yeah,
mess. I'm gonna jump ahead.
yeah,
Oh wait, no, this is the part that at the from the
hmm
other presentation, right?
yeah, the CFL.
All right, you want to talk about this real quick? We'll end on this.
Yeah, so this is the kind of showing, how gross instability this ankle is. And, there's a fluoro here. So, no guesswork here. You already have a varus tilt that you can see. And so, this kind of shows that top image, that the CFL anatomy, how it has more of a posterior orientation. And then what it actually looks like. This is like a healthy CFL, and you see how robust that is.
Hmm.
Um, and it's really not that much of a dissection. I mean, yes, it's a little bit more, but like, hopefully you know how to do the perineal, you know how to expose the perineals, you reflect them inferiorly, and then, a lot of times you have to kind of tease that out. So I use like a right angle to kind of parse the CFL and separate it from the surrounding tissues, but you can see how robust that is. You can't miss that. So,
Yeah, that
man,
thing
that's
is
just like
just
you can't do a brostrom on that. Like, come on.
yeah. People do. Look
People
how
do.
loose that
They
is.
do.
Yeah,
That is a floppy one. So
yeah,
yeah, but that's kind of my incision approach for it, but you can do, like on that left image, that's, a standard Brostrom kind of approach. But if you can extend that more, distal posteriorly, and you can get access to the CFL, but it is a little bit harder from that approach. So I just like to go right over the perineals and kind of curve it up um, on the superior margin of the perineal brevis. So,
Yep, that's what I do too. You can get to perineals, you get to ATFL, and you get to
yep.
CFL all from that same incision.
Yeah. So I know there's a lot going on here, but we've already started here where I anchor so I use an internal brace, and then this is already anchored into the neck of the talus, right? And so now this is kind of my technique for it essentially. And basically what we're doing is we're creating a fibular tunnel. And this is a technique that basically is just stolen from what we used to do with tendon allografts, right?
Mm-hmm.
The reason why I like more of a no stretch construct is because we've seen in the literature in the knee where patients have been using tendon allografts that they become lax over time. And so what we're doing here is we're making an incomplete tunnel utilizing the drill bit that comes in the internal brace kit, starting anterior to posterior. And
Mm-hmm.
then what I do is I leave that wire in. And so it gives me a targeting guide. And now I'm aiming the drill posterior toward that drill. And when I see it shatter, that's
Mm-hmm.
when I know to stop, because if you keep riding up the tunnel, then when you put your suture passer, it can keep going up that posterior tunnel.
Mm.
And so for me, once you get once the suture passer goes in and it can't go further up the fibula shaft, then it exits out anteriorly. And
Okay.
that's what you see in the bottom images. And so now we're
Yeah.
just whipping that through, routing it through the tunnel, pulling it in, um, and then we'll seat it into the calcaneus.
So you're basically anatomically recreating ATFL and CFL
Correct.
all at once.
Correct. Yeah, yeah. The reason why I like this is I like more of an anatomic repair as opposed to. So the reason why I really looked into the CFL is because I was actually I was having a lot of revision surgeries from just other surgeons doing a CFL technique where kind of the standard. I think when the internal brace came out is you anchor it into the fibula and then you just bring the extra arm down. And what I was finding is that I wish I captured them in the scope or saved those images, but I could see them in the gutter. And
Mm.
these patients were complaining of a lot of impingement on the lateral
Mm-hmm.
gutter, and I
Mm.
think it's that internal brace sliding in there, and it just wasn't anatomic, and they were getting a little bit of just like I said, impingement, and so I had to undo it, revise it, and kind of revising it in this way. And so this, like I said, is a more anatomic repair because now I can route that internal brace right over the CFL, and I kind of adopt the method where I don't, I want to allow some physiologic range of motion. So just like I do with the ATFL, I allow some inversion, and
Yeah.
then I anchor it. And so I put an anchor into the fibula, and that way I independently secure the ATFL and CFL. So that
Okay.
if I, in the case that I over tighten it, I can actually cut one of them without compromising the other.
Sure.
And it prevents the internal brace from doing this like kind of sawing motion in the
Yeah.
fibula.
Sure.
So,
That
um,
makes a lot of sense.
mhm.
That's great. That's good. You're stabilizing um, ATFL, CFL all at once. I like that technique. That's a good technique. What
Yeah.
do you?
So go ahead.
I was gonna say, what are you aiming for? What position point? I think I can see it there on the fluoro image. I got the answer to
Yeah.
my own question, but what are you aiming for your insertion point into the calcaneus?
Yeah, so I usually go about right where you see that K wire go in is essentially in the middle and inferior aspect of the posterior facet of the subtalar joint,
Mm-hmm.
because that's where the CFL inserts. And so, and that wire kind of serves as like a retractor for my, for the perineals. So,
Hmm.
so yeah, that's kind of the targeting guide. And you can see once again, that varus tilt post the rostrum repair. And so, once again, even with augmentation, after I've secured the internal brace, I'll put a scope in there, stress it, and then if I'm wrong and then there isn't any more, varus tilt, then I'll just cut the extra arm, and then we're
Mm-hmm.
done. And I've
Yeah.
imbricated the CFL, and at least we're tight there. But then if it's not, then like I said, this needs something more, and that's where I secure the internal brace.
Nice. I like that technique. What are your thoughts on over tightening? Possible, not possible? I mean, I know it's possible. What are your
Yeah.
thoughts on over tightening that with the internal brace?
Yeah, I mean, it's definitely, I think, the one of the probably higher complication rates that we see with the internal brace is either under or over tightening. I think probably over tightening is one that I see in, at least in my practice, more often. Luckily, I've been good. I haven't had any over tightening. I guess I'm really scared of it because I treat a lot of athletes,
Hmm.
and so I've had a few under tightening for sure, but not enough that they wanted revision. So, I mean, it kind of depends. I think some people, depending on what you're treating, like if you have something with like gross instability, or you're trying to prevent movement within the ankle subtalar joint for particular reasons, and I think that's fine. But I think you have to be very, very specific on that patient. Like an athlete that is so in tune with their body is not going to be happy with that. They're going to be very, very upset and irritated.
Yeah.
So I don't think that's the right population. But someone where you really want to lock up motion, maybe there's like I don't know, like maybe like I don't know. I've seen some people protect with like TARs and using them. Maybe that's a scenario. I haven't done one for that particularly yet, but
Hmm.
trying to think maybe a ligamentous laxus person. But even then, a lot of the Ehlers-Danlos patients that I have are fairly young, and
Hmm.
they want some physiologic range of motion.
Sure. So my technique for lateral ankle, I do this modified technique. I don't know if I invented it or if I saw it somewhere. I've been doing it so long, I honestly can't remember. But I'll put two anchors. This is for someone who maybe I'm doing a perineal tendon repair and I'm protecting the perineal tendon repair rather than that like severe ankle varus, like that severe
Mm,
ligamentous laxity. So not an internal brace candidate, but I put two anchors in the distal tip of the fibula. I fan them out through the ATFL and then tie them down. I
hmm.
use the knotless ones that kind of you can
Yeah.
tensionable
Yep.
afterwards, and you tension them down and you lock that in place. And then I take the tails and I route them subperiosteally up to a lateral fibular anchor. And so the first anchors are kind of going from fibula towards the talus, almost like horizontally. And then the next one
Hmm.
is almost bringing it vertically. It's almost mimicking like a CFL type
Hmm.
prevention of motion, but it's
Hmm.
from ATFL up to the fibula as opposed to down to the calcaneus.
To
The
down.
benefit of that is that I don't have to open all that stuff up down there if I don't have to. And just anecdotally, when I do the first part and I do the talar tilt and then I do the second part, I can feel a significant difference in the lateral
Mm.
ankle stability. It's like a non-anatomic lateral ankle repair. But I've just
Yeah,
been
I see
doing
it.
that now, and it seems to work really well. It adds a lot of lateral stability. I'm not smart enough to really understand what's happening there, but maybe the more vertical nature of the
Yeah.
alignment is
Yeah.
limiting some of that inversion versus the more
Yeah.
horizontal aspect of the ATFL repair. But it seems to work pretty well.
Nice. Nice.
Yeah.
Yeah, man. You need to get that out, man. That would be
I just
interesting.
did.
So,
I just did.
yeah. No way.
This is me.
Okay.
No, this is me getting it out. Like I
This
don't have
is
time
you.
to write
Okay.
article. I have time to talk into this thing. I don't have time to write it all down. I'm just
We got to get you a
here it is.
resident to do it for you.
Yeah, exactly. Put them to work.
Nice.
All right, man. Thank you so much for joining me tonight. I think this has been
Yeah.
fantastic. I've enjoyed catching up with you, and thanks for hopping on tonight.
Thanks for having me, Jeff. It's been a pleasure.
Yeah, absolutely. Thank you, everyone, for listening to this episode of Paw Patrol with your host, Dr. Jeff Dikis, joined by Dr. Colin Mizuo. Until next time, thank you.
Disclaimer. Opinions expressed are those of the content creators and do not represent any employer or entity. The information shared is for informational purposes only and should not be construed as medical advice or used in any legal capacity, including establishing standards of care. All efforts have been made to comply with HIPAA regulations. No guarantees are made regarding the accuracy of statements or opinions provided. Interaction with the podcast does not establish a doctor-patient relationship. Please enjoy this podcast responsibly.